We subsequently came to understand that the foods that we were asking patients not to ingest, namely the oils, dairy, meat, fish, and chicken, were the foods that we have subsequently come to recognize. Immediately when they pass your lips, these foods injure the magic carpet that is our guardian, that is our life jacket, which is this lining within our blood vessels, where all experts now agree that it's that endothelial lining that is the absolute guardian of our blood vessels.
So you're looking at the inner lining of the artery, right? And when that becomes injured, you can then develop atherosclerotic plaques. You can develop a narrowing. The vessel no longer contracts and widens properly. Is that what you're saying?
Yes, you're absolutely right. There is a sequence of events that begins to occur that injures the vessel, and that's that combination of things. Because the magic properties of nitric oxide are, it keeps our blood flowing.
Wait a minute, what is nitric oxide?
Nitric oxide is that magic molecule of gas which is made by the endothelial cells, which are healthy. And when you are a kid, 5, 6, 7 years old, you have a level of nitric oxide. Well, it's way up here above your eyebrows. But even as a pre-adolescent, you start getting exposed to these nasty foods that are so beginning to injure your endothelium right on through your teenage years that by the time you're 20, sadly, if you get killed in combat in Korea and Vietnam, the chances are over 80% that you're already going to have gross evidence of coronary disease. Now, that was 40 years ago. But if we repeat the study in more recent times, without the stress of the military, because that's what some people said was causing it, you look at women and men between the ages of 17 and 34 who've died of accidents, homicides, and suicides in 1999. The disease is now ubiquitous. Not enough yet to have your clinical cardiac event. It's pretty profound.
Oh, I see. So for instance, coronary artery disease is developing unnoticed by the physician or the patient, but it's developing asymptomatic, and it has to do with a lessening of the nitric oxide, which is, as you said, it teflonizes the inside of the artery so it doesn't get sticky and develop the plaque. Is that what you're saying?
That's one thing, and then you mentioned also the next important function. It is the strongest vasodilator in the body. That is to say, you climb stairs. Yes. The arteries to your heart dilate. The arteries to your legs widen and dilate. Nitric oxide also inhibits inflammation from developing in the wall of the artery so that you don't get hypertension. Keeps the artery nice and soft and flexible. And nitric oxide also, most importantly, prevents the formation of plaque. But if you keep lowering throughout your youth and your early middle age, keep lowering your nitric oxide levels, then all these rascally plaques can begin to develop as the inflammation grows and grows in the artery. But
so tell me, so you have these 24 patients, they're being sent to you, they're inoperable, they're kind of almost the walking dead. I mean, they don't know what else to do, their back is against the wall, they cannot be operated on.
Some are told they go home to die. Go
home and die. So they come to you. Well, that's quite a crop to take care of, isn't it?
Yeah, but you know, the wonderful thing was that they grasped the importance of what it was that we were trying to do, and they really got behind it, all but a special few, and we got very exciting results.
So you enrolled these people into your program. You were aiming for a simpler diet, I mean more natural foods, more unprocessed foods, no animal products?
No dairy, no oil, no meat, fish, and chicken.
Okay, so it's a very, shall we say, simple diet, an attractive diet. It can be prepared very, very nicely.
Correct.
Yeah, but you also prescribed exercise?
We certainly encouraged exercise. I think when I didn't go into the part of prescription. Exercise was encouraged, but I'll tell you why I didn't really make it an absolutely vice-type exercise prescription. You know, every day, 40 minutes on the stair climber.
Yeah.
When you're dealing with behavioral modification, everybody becomes aware that each of us has within us just so many behavioral modification units.
Oh.
And I don't want those behavioral modification units to be consumed with compulsory exercise and then somehow have the food. Food trumps it all. Because we had patients, for instance, we had patients who had strokes. And Hans, they couldn't exercise.
Yeah.
But in no way were they precluded from enjoying these same benefits.
So you had a program that focused on foods as grown, unprocessed foods, non-animal products, and you were aiming at getting cholesterol levels down to less than...
Well, we were ideally wanting to try to keep the total under 150 and try to get the LDL as close to 80 as possible. Yeah.
Okay, so to regress the disease, to open up the arteries, to have a melting down of these plaques, to open up the nitric acid to do its job properly, you felt it was important to bring those cholesterol levels down as low as possible.
As low as this type of nutrition would take it.
Yeah.
Yeah.
I mean, you go to China and you see cholesterol levels of 100, 120, 130, 140, right? In America, it's over 200.
Right.
So you really wanted to have optimal levels below 150.
But
did you succeed in that?
Oh yeah. Oh yeah.
What, largely with diet?
Absolutely.
Okay. How long did it take you? A year? 6 months?
To get
2
the numbers,
weeks?
to get the number down? Oh, I think I would think within 2 or 3 weeks you really ought to see where you're going. Absolutely.
So you're bringing cholesterol numbers down within 2 weeks.
Oh, yeah.
That usually takes 2 weeks with medication. It's true, isn't it?
Yes. But you know, the exciting thing is that I have to add now that if I was to review this all over again, I would still say that I want people to think about getting their numbers into that range. But let's suppose you've got, all of us have a different liver. And suppose your liver doesn't want to crank out 150. Let's suppose it ends up saying it only was going to go down to 165 or 170. However, if you are still eating the healthy plant-based diet, let's go back, you are not at all injuring your endothelium. So the endothelium is still going to be able to regain its capacity to make plenty of nitric oxide. And even if you have a cholesterol of 165, 170, that cholesterol is almost like an innocent bystander if you've got lots of nitric oxide, because that is protecting your artery from being injured. And the other thing we haven't spoken about at this time is one other thing that has really emerged as very important, that almost by serendipity, that I think that we were also doing that was very beneficial. And that was, we'll take a little break, the HDL cholesterol. We all talk about HDL, good cholesterol, LDL, bad cholesterol. We talk about the total. But it's the HDL cholesterol which is supposed to be our great protector. And for years we have felt that if you had a high HDL, you were...
That was the mantra in cardiology, right?
Yeah, and what happens, as soon as patients would start eating our plant-based diet...
Well, but the chip program too.
Not only would the bad LDL cholesterol fall, but so will your good HDL cholesterol. Now...
What's the reaction from the personal physicians?
Oh, well, the minute they think, get off that program, it's lowering your good HDL.
Yes.
But wait a minute. I was able to say, look, our patients that now have lower than normal HDLs, we're reversing their disease.
That doesn't make sense then, does it?
No.
It's not very congruous, because if HDL should be high to protect, and our programs begin to bring the HDL down, something's not quite right, is it? And yet you have a lessening of heart disease.
But at the same time, people will be entering the program when they had their heart attack. Their cholesterol, their HDL cholesterols were up there in the high upper range of normal. And so the University of Pennsylvania recently did some wonderful studies measuring the capacity of the HDL molecule to what we call efflux, which is to say, it'll take the bad cholesterol from the wall of the artery back to the liver, where it will help and make this invasion of cholesterol into the artery wall become harmless. But what they found out that was so exciting is the level of HDL cholesterol does not correlate with its capacity to do its job efficiently.
Now, let me interrupt you right there.
Yeah.
So it is not so much the absolute number for HDL that is so important. You say the capacity. When you say capacity, the ability for HDL to do its function of being protective for heart disease. So you can have a lower number, but it can have a higher capacity or ability to protect.
Correct. And where you see this in spades, for instance, is if we look at our friends, the Tarahumara.
Yes.
Their normal HDL cholesterol is 25, which
Yes.
would drive the average cardiologist apoplectic.
yes.
So the key thing here is to remember that when you are eating the Western diet, and you may say, well, I'm okay eating this diet, Western, I've got this high HDL. Mm-hmm. That high HDL, not only is it no longer helping you, mm-hmm. but when that HDL mm-hmm. molecule is now residing mm-hmm. in an inflammatory atmosphere, mm-hmm. it becomes injured. Mm-hmm. And it no longer, not only can it not help you, mm-hmm. it itself becomes pro-inflammatory, behaving like your bad LDL cholesterol, mm-hmm. contributing to the disease. Mm.
So this numbering could be very, very misleading. Now, two questions. How do you measure the capacity, the ability of this good cholesterol to be serviceable to you? Is there a test that one can end, or is this in the making, or where are we in the science?
Everybody is clamoring for this to be a test that is more readily available. It still is a highly done in an experimental research model that is not yet easily transferable.
So this is cutting edge information, or just came out last January, right?
About 8 weeks ago.
Yeah. So the capacity, the ability of HDL, the good cholesterol, to be protective is a key issue, not so much the number, the absolute number of the HDL. Very important. The second question, you talked about nitric oxide. You know, I learned a lot from you about this. You are Dr. Nitric Oxide to me. Yeah, you are. Now, you mentioned to me that people received the Nobel Prize for identifying nitric oxide and its function. How far has the analytical laboratory science come to develop a test to measure the nitric oxide? Can that be done?
You know, interestingly enough, it is very close to being there by what we call the brachial artery tourniquet test, which is one. Another is a peripheral arterial tonometry, mm-hmm. Both of which are capable of really quite easily measuring nitric oxide.